Now it's a pleasure to introduce the last speaker before the coffee break, Alessandro Cassini, from European Center for Disease Prevention and Control. And amongst others, Alessandro has led the Burden of Communicable Diseases in Europe project. And I think that's also what we are going to hear about here in your presentation. So Alessandro, welcome, the floor is yours.
Well, thank you very much. You see the presentation now. So thank you very much for inviting me, and actually what I will be presenting now fits perfectly with what Ari and Kostas have presented. So as you were saying, I work at the European Center for Disease Prevention and Control, and our perspective, respective to EFSA, is slightly different. So EFSA is a bit our sister agency, but we have the hazard perspective. So as the gentleman earlier was asking, why didn't we have a perspective looking at the pathogen? So this is where we come in, and we've developed a project, and within this project a software, a toolkit, which will be available soon on ECDC's website for downloading. Which is sort of a DALI calculator, and I will explain a little bit more about it right now. So in general, why we started to do the Burden of Communicable Diseases project is, of course, because we need to rank risks and pathogens for many different reasons. Here, I sort of suggest to just highlight one of the reasons, which is allocating very finite, definite resources in public health, which is an increasing problem, especially relevant right now in most European countries where the economic crisis has had an impact. And member states in the European Union have asked us, the public health agencies in the European Union have asked us, can you please provide us some help, provide us with tools in order for us to better understand how to allocate these resources. But it's not the only reason. It's also because we help member states in developing preparedness activities in order to understand how to deal with emerging threats and with existing threats that already are happening in the whole of Europe, but also in specific member states. So, in general, this is the cycle of preparedness activities, but what we concentrate and where we really focus the most is to identify the risks and how to prioritize the top risks. So how to prioritize the top risks? There are several ways. You actually can have, as Kostas was showing earlier, very qualitative type of methods. You can have semi-quantitative and actually quantitative, like multi-criteria decision analysis. I'm also involved in another project in ECDC where we suggest other kind of multi-criteria decision analysis for ranking emerging threats. But now what I will show is what we consider in general the most robust way to rank the risks. And we will be publishing soon, always on Plus, probably more or less just after the FERG results, the results of what we call the BCODE 2015 project, which is not only foodborne diseases. In general, it's all infectious diseases that at least ECDC is following and is responsible for. And they include, of course, vaccine-preventable diseases, sexual transmission diseases, etc. But what I was saying is that in general, this is what we consider the most robust way of ranking risks. It's not the easiest, and Ari was mentioning earlier that it took them 8 years to get to the conclusion this year, and it took us about 5-6 years to do our project too. Now, once we've done it once, it's much easier to redo it, and I think we should be continuously updating the burden of disease study. But in general, it is a data-intensive kind of endeavor that one has to take if they want to do a proper burden of disease study. So we wanted to assess the comparative impact of infectious diseases. We have a lot of different infectious diseases. We have vaccine-preventable diseases. We have foodborne diseases that we survey in Europe, and they are very different. Some have very high incidences, but low mortalities. Others are the opposite. So how can you really compare these apples and pears? We decided to use evidence-based methods and DALIs. And thank you very much for presenting the methodology of DALIs, Ali, actually, because I did not include those slides on the actual methodology. So thank you very much. We've also been working with a large academic consortium across Europe that included universities and public health agencies. And we've developed a lot of disease models, those outcome trees that Ari was showing earlier. We had to go through all the notification data, and ultimately it was a big exercise to actually understand what was the underestimation of notified diseases across Europe. It was actually very interesting to see what it does look like, and also what is the quality and availability of the surveillance systems and the data that they produce. So within this bigger project, instead of using all a series of Excel sheets, we decided it would be easier for us, but then also for member states that wanted to do their own national burden of disease study, to use a toolkit, a very easy to use, let's say, way where they just needed to put in the incidence data and it would calculate the DALIs for them. Not only that, but we also wanted to give them the possibility of having visualization tools that they could use in order to better interact with managers later and decision makers. And therefore, we started creating a software called the BCODE Toolkit. So when one opens the toolkit, by the way, it will be available, I don't know if I already said that, very soon, within a month, on the ECDC's website for downloading. It's completely open, so we ask only to register your name and your affiliation, but then you can download it as a standalone application. When one opens the toolkit, this is the first page that they see, and we have created an embedded tutorial with some generic concepts over here so in order to better understand the methodology, how we've worked out the uncertainty, the tables, and all the parameters that one can edit within the toolkit. And there's also a flow chart that can work actually, can work as a walkthrough. So it actually walks you through the whole process of producing estimates. It's very interesting. Or also it gives pop-ups with full explanations of what the different parts of the tool actually mean and how to use them and how to interact with them. And then this is an important page where one creates the models. So let's say that there's a public health expert in one of the member states, let's say in Italy, in Rome, at the Istituto Superiore di Sanità, who wants to know what is the burden of infectious diseases in Europe. So they would click on Italy and then click on the diseases that they wanted to estimate the burden for. And that would generate a series of models. So one model for each disease. One can also compare different regions with different populations. So all they need to do is click on custom population, and then they would edit the population within the models. Or one can want to compare the same disease but in different settings. So you just create 3 or 4 or even more models of the same disease, let's say measles, and compare the different burden of measles across member states or regions. And then this is the actual input page. The main and compulsory input table is this one, where the user has to input the number of cases. Next to that, the user would have to, but not compulsory, have to input the number of underestimation that they think is actually occurring for the model that they're looking at. So it could be underestimation in one, or here as the example that I show, in two tables, underreporting and underascertainment. After inputting, if one hovers the question marks, it explains how to input the data. I usually prepare all my data on an Excel, on a table, and then just copy and paste it directly in here. It's easier. So it's also interactive with Excel, both in importing and in exporting. Here is where you can change the data, you can fill the table with the same formula, or actually paste or copy from a clipboard. And then you can select and go from one disease to another with this menu over here. It's pretty simple to use. And the user can also browse, well, before the outcome tree, generally the population data over here, where you would find two tables, one with the actual population per age and gender, and the life expectancy. And by default, the population is the one that one has selected, and the life expectancy would be more or less the same standardized life table that Ari was talking about earlier. You can look at the outcome tree. You can actually also go around the outcome tree and find out what are the numbers, what we call the parameters within the outcome tree. These are disability weights, what is called severity here, the same that Ari was talking about earlier, and also the duration of the different outcomes. And these are also interactive, and if you think that in your member state or in the situation that you're looking at, these are different, you can always edit them and change them. You can also change the transition probabilities, which are the risks of developing the different sequelae that you can see here. That yellow box that you see over there is where your actual incidents, your actual cases go into. And you can also look at why we've made certain decisions on the diseases that are included. So these are the results of the literature reviews that embed and that underlie each of the models. So here you can read and criticize us for the decisions that we made on this and change the parameters later in the models. And then the whole tool is based on Monte Carlo simulations. So here you can choose the iterations, the number of iterations that you want to run the model for. And also in the one before here I show also you can decide if you want to time discount. So age weighting and time discounting are two, let's say, possibilities that have been involved with burden of disease studies. Age weighting we have discarded completely. It actually means that if you get a disease at a certain age, let's say generally in the elderly, these account for less DALYs than if you get it during your productive years. And for ethical reasons, we decided to discard this completely. Whereas time discounting means that whatever happens, meaning the sequela that would happen in some years' time, account for less DALYs than what actually happens today. And we've decided to keep the option here if one wants to estimate the DALYs with time discounting, because it's generally a more accepted method when you want to do economic analysis. So we've kept this as a possibility. But in general, at least in BCODE 2015, we show the results without time discounting for the same reasons Ferg showed theirs without. We think that it's not something that, at least when you look at population health, is interesting to actually account for. So you run the models. Here, by default, it's 1,000 iterations, but you can go up to 100,000 iterations if you think you want that degree of precision. And then there are two main, let's say, tabs to see the results. One are the detailed ones, and the other are the aggregate. So the detailed ones, you'll see that you can choose which disease to look at over here. And there's a lot of very, let's say, a lot of information on the contribution of each sequela and the incidence to the overall DALYs for that disease. And you can also see that in charts, in a pie chart to see what are the contributions of the different sequela, and also in a bar chart to see what is the contribution of the acute part of the disease and the sequela to the overall burden of that disease. In the aggregate results, we have several ways of showing the results. ECDC is in Stockholm, so when I go to eat, I go to Karolinska, and I often see Hans Rosling. And so I had the idea, why don't we also include, I don't know if you know, it's a statistician at Karolinska Institute who created the bubble charts, or at least had the idea to show summaries of population health, and not only through these bubble charts. So we included those once over lunch. I asked him if it was okay. He said okay. And here you can actually map the general burden of each disease, which is the diameter of the bubble, according to the incidence or the mortality. So how much is brought from the incidence, or how much is brought from the mortality. You can have a table with the actual ranking. So these, I think, this is an old, this is the results of burden of BCODE 2015. When I showed this to the European Commission, this was all they were interested in. So in general, decision makers really are interested in this final result only. Of course, there's a lot of uncertainty around these numbers, which are not shown here, but when you actually export this table onto Excel, the uncertainties are very visible. And this table is interactive. If you click on, for example, the YLL per 100,000, the table will then regenerate a new table according to the diseases with the highest YLL to the one with the lowest YLL. So you can change your table according to the metric within the DALYs, of course, that you want to look at. You can also generate both for every specific disease and for the group of diseases that you've selected, more detailed tables on the DALY per case, DALYs in general, and DALY per 100,000. And also what we decided to use is DALY per age group stratum to understand if there are age groups that have specific risks that are higher than other age groups, with the uncertainty intervals here as well. And these are exportable. So in general, as I was showing earlier, we did the BCODE 2015 for several reasons. But in specific, I wanted to highlight a bit of the objectives of the overall project with giving you some examples of the outputs through those objectives. So what we wanted really to do in Europe is to continue on fostering an evidence-based approach to health description. I think this is important to understand that at ECDC, not only we deal with surveillance systems that are very different, heterogeneous across European member states, but also the approach and the capacities to evidence-based health descriptions are very different. So we wanted to convey the message that there is a simpler way, but it is more robust to understand what is the impact of infectious diseases across Europe. So this is more or less the diagram that Ari showed. We decided to use DALYs. We also did a lot of literature reviews in order to understand what were the natural pathways of the diseases, and be sure that we are accounting for not only the acute phase of the disease and how much that impacts, but also all the sequelae and how much they impact as well. we built all these outcome trees, so that have a lot of parameters, the risks of developing sequelae, the disabilities related to certain conditions and outcomes, and also the durations of the diseases as well. And we've published an article some years ago where we outline our methodology, which is very similar to what Ari was showing earlier. Incidence-based approach, pathogen-based approach, which is slightly different from what the Global Burden of Disease Project is doing. They have a prevalence-based approach, but we think that for infectious diseases, it is more relevant to have an incidence-based approach. We've had to review all surveillance systems across the European Union and for a certain number of years that were included in our project. So this is, I don't want you to look at the table, but just to show you one of the tables for one disease, looks at all member states and what are their surveillance system for that specific disease. We had to go through with that with the member state experts, but also with our experts at ECDC who know surveillance systems very well. And then with the data that we collect at ECDC, which are notified data, and with that information on the kind of surveillance system that is producing that notified data, we also had to look at the surveillance pyramid and understand what is actually this difference between what we see, which is always the tip of an iceberg, and the amount of symptomatic diseases that we actually have in the community, and how many of those are complicated, how many are not, how many go to the hospital, etc. And that for every disease, and in general, not for every member state, but for, let's say, groups of member states. And we've also developed a methodology on measuring this underestimation, which was published a couple of years ago, or last year, I think, where we actually determine the difference between underestimation, underreporting, and understatement. We wanted to create tools that facilitate communication of very complex information to decision makers, and ranking diseases and risks in this way generally we think is a better way or an easier way to communicate. And these are the actual results of BCODE 2015, where you can see, or I've sort of highlighted some groups of diseases where it's very easy for a decision maker to see which are the pathogens or the diseases that impact the most across Europe. We also created these bubble charts that I showed earlier, where it's simpler to understand, well, what is it that actually impacts the most for that disease? Is it the mortality, like here for the pneumococcal disease, the red one, or is it more the incidence? And I think that yellow box is Campylobacteriosis. And we wanted to provide the tool for planning and prioritization. Now, this list here that you see is the list of infectious diseases that are reported to a database that we have within ECDC called TESI. So every year, member states are required to report and notify the number of cases, and it's a case-based database. So if you just look at the amount of notifications, it seems that chlamydia is the biggest problem that we have in the European Union, but actually it's different. The ranking of diseases is different. So just wanted to show you how it completely changes. The ranking here that you have on the right is slightly different from what I showed earlier, but in general what I mean is that when you use DALIs, this composite health measure, it will change completely the ranking of diseases. It gives you a new perspective. And as Kostas was saying earlier, it's very important to agree on the metrics that you will be using later. And always to remain on the planning and prioritization, I want to give you 3 examples. Some months ago, a fellow in Slovenia was working, an epidemiologist in Slovenia, was working on the new strategies for tick-borne encephalitis vaccinations in their country. And they were thinking, okay, let's look at the incidence, because we have don't have a lot of resources. We cannot reimburse vaccination to everyone. Let's see which ones are the age groups that actually have the biggest incidence, and we will reimburse vaccination to those groups. And these are the annual number of cases, and they thought, okay, these ones, the around 55-year-olds, are the ones that have the highest impact. Will reimburse between those who are 45 to those who are 65 years old. Then together we started thinking, okay, but why don't we look at it differently and see what is the actual burden per age group of tick-borne encephalitis. And after we've produced this graph, that hopefully we will be publishing soon, the health authorities in Slovenia are reconsidering their thoughts on which are the age groups that they should reimburse the vaccination for. So, because as you can see here, it's really the younger populations between 1 and 10 years old which have the highest impact if you are actually looking at DALYs. So they are really the age group that are at risk. Another example is measles. Now, this is the same burden of disease ranking that I showed you earlier. What I'm highlighting here is that in 2010 in Europe, we've experienced a huge outbreak of measles, more than 20,000 cases. And in particular, in one of our member states, the burden was particularly high. And at the same time, there were pockets of the population with a very low vaccination coverage. So let's say the public health authorities there, they could have, at the time, shown, or anyway will also show, that if nothing will be done in order to improve the vaccination coverage, because measles will happen again there, what they will experience is a burden as high or slightly lower than HIV and more than invasive pneumococcal disease if they don't do anything about that. So as you can see, measles normally is down over here because vaccination is pretty good in Europe, but if vaccination, especially in some pockets of the population, does not hit those more than 95% of vaccination coverage, the burden is bound to be over there. And last but not least, we were involved with the European Commission and with EFSA on considering new legislation for Campylobacteriosis control and prevention in broilers. And one of the first steps, well, where we've been asked to estimate what was the impact of Campylobacteriosis, we produced this diagram where we show that it's very clear how Campylobacteriosis is the disease, the foodborne diseases with the highest impact in Europe and European countries. Although, of course, uncertainties are pretty high, it still seems to really be the one with the highest impact. And last but not least, in practice, what it also means is that this toolkit hopefully will start not only to be used in member states, but also in other EFSA risk assessments when they will have to decide on the biohaz risks. And one of the conclusions of the scientific opinion that Kostas was talking about earlier is that a top-down approach should be considered together with a bottom-up approach, and the two tools that would best or would be more valuable for these two approaches would be the BCODE toolkit as the top-down and iRisk as the bottom-up approach for risk ranking. So thank you very much.
Thank you very much. We are on time. I think we have 1 minute for a clarifying question before coffee break. Yes, Marion?
So thank you. I'm wondering, because we heard the two different presentations on burden of disease, are you also going to give us a guidance on where the estimates are going to differ and how that is affected by different methodologies? Because to me that seems an important issue.
So the methodology is basically the same, and we've been sharing our models together with a fur group. So I went to some of their meetings, and we provided and shared most of our... They have a different perspective. They're looking not only at the burden of foodborne diseases, but also and mainly at what is attributable to food. Whereas we're looking really in general at what is the number of diseases that happen across Europe, and not only food, but also the other infectious diseases, and we limit ourselves to Europe. And I think one of the most important outcomes that will come out from FERG is the burden in regions that really have a huge problem, not only for diseases like Campylobacterius or rotavirus, but also other diseases that actually kill a lot of people, like in Africa or Southeast Asia.
Okay, so thank you very much to all speakers. Now it's coffee break, and we will reconvene 11:15. Thank you.